going live in 5, 4, 3, 1. We are live now.
Good evening, everybody, and welcome to today's evening's webinar. Today we have Dr. Arvind Gupta from Paras HMRI, Patna. He's going to talk to us about ankle arthroscopy. As you're aware, arthroscopy is replacing a lot of situations where we earlier needed to do open surgery, and has also opened a new sort of vision of what all you can have as problems in the ankle or the knee joint or the shoulder joint and how to deal with them. So ankle is one of the joints which has been a little late to take off on arthroscopy, but to tell you what the possibilities are and what we can do here in Patna, it's over to you, Arvind.
Thank you, sir. Thank you for the opportunity again. So my slide is there.
Yeah, that's fine.
Yeah. So today talk is about basic of the ankle arthroscopy and what are the recent thing has added to this. So this ankle arthroscopy start with the positioning of the patient. So if we are doing the anterior ankle arthroscopy, so position is usually supine, and in case if it is the posterior ankle arthroscopy, then the position is prone. And since ankle in ankle there is problem with the space, we have to insert the trocar cannula and instrument. So instrument has been designed to distract the ankle. So this is the distractor, in which there is a triangular type of thing has to attach it over the back of the heel and the dorsum part of the foot, and through which there is distractor is attached, and you can pull as much as possible. If it is not available, so what we are using this type of thing, and one assistant has to hold this throughout the surgery, and this is the way we are doing in most of the time. And another thing, if you have to do the diagnostic part only, then again you can insufflate the joint with around 20 ml of fluid, like something like this. In this way, you distend the capsule, because almost 20-25 ml of fluid will be inside the ankle joint. You can see how ankle is getting distended, and you left the needle and remove the inject this part, and you can see the water is coming back. It means you are in the joint. Again, this is the position of anteromedial portal, also the same, where you need to make a portal. So joint distension you can create in this way also. Next is the portal. That is the first is anteromedial portal. That is also a primary weighing portal. This is made in between medial to the tibialis anterior tendon and lateral to the medial malleus. That we have seen in the previous slide also. And after identifying the soft spot, you just incise the skin with 11 number knife, and then you spread with the help of artery faucet. So this technique is called as the nick and the spread technique. And then you insert your trocar cannula inside the ankle joint. And then you next photo, you're just like this. So this is one of the case of ankle. Just after going into the facet, this is medial facet. So once you start from the medial side, then you move toward the lateral side. And once you are on the lateral side, this is the lateral side of the ankle joint. This is the tip of the fibula, and once you are on the lateral side of the ankle joint, then you make needle, pass a needle just medial to the fibula and lateral to the this peroneus tertius. And the dotted line you can see here is the superficial peroneal nerve, which is one of the complications of ankle arthroscopy, the damage to the superficial peroneal nerve. So you can see from inside out also, and initially you can mark this superficial peroneal nerve, which is in the line of the fourth metatarsals is there. So in this way you can prevent the injury to the superficial nerve. One, you can make the marking before starting the arthroscopy, and second, you can see from inside. Then your area will get trans-illuminated, and then you pass your needle, and this way you will be exactly on the spot where you want to. So this is the anterolateral portal here you want to make. And next is the anterocentral portal, that is anteriorly in between the EDL and lateral to the EHL, that is medial to the EDL and lateral to the EHL. Here is the chances of injury to the dorsalis pedis artery. So this portal very less use in very less use. So next ankle arthroscopy in the posterior side. So the next portal is the posterolateral portal. In this position of the patient is prone, and you make a portal at the level of the joint line posteriorly in between the lateral malleolus and the tibialis tendon. Usually from the tip of the medial malleolus is around 2 centimeters below the joint line. So usually your portal is around 2 centimeters above from the tip of the lateral malleolus. Next is the posterior-medial portal. Again, that is the portal on the medial side, just medial to the Achilles tendon. So in ankle arthroscopy, the instrument we have availability of arthroscope of 2.7 also and the 4 mm also. So if you will use 2.7 mm arthroscope and 2 mm saver, this will be more friendly to the joint. The chances of cartilage injury will be less and other structure injury will be less. But you can go with 4 mm scope also. We are doing many a times with 4 mm scope once the joint is distended. So it's depend upon the space, how much you have created inside the ankle joint. But the preferred one is the 2.7 scope and 2 mm of the saver. About the indication of this ankle arthroscopy, so it's maybe soft tissue lesion or bony lesion. So in the soft tissue, it may be a synovitis of the ankle joint, maybe impingement, which may be anterior, which may be anteromedial, anterolateral, posterior, maybe posteromedial, posterolateral impingement. There is syndesmotic impingement, syndesmotic injury. There may be lateral ankle instability. And in the bony part, there may be osteochondral lesion, there may be loose body, osteophytes, there may be degeneration of the ankle joint, and maybe ankle fusion. And nowadays, a lot of people are putting a scope in the fracture around the ankle joint also. So the basic principle of looking into the joint did not change over the time, but the technical innovation make it possible to visualize and perform more specific procedure. Like this is the case of synovitis of the ankle joint. With ankle arthroscopy, we can do the complete synovectomy. We can take the biopsy, and at the same time, with diagnostic arthroscopy, we can also many a times make diagnosis, like many a time is pigmented villonodular synovitis, or if there is septic in this synovitis because of sepsis. So all these can be identified by doing this diagnostic arthroscopy of the ankle joint. Next is the soft tissue impingement. So impingement of the ankle joint may be because of the soft tissue or maybe because of the bony part. In soft tissue impingement in the anterior part, it's mostly on the anterolateral side. So it's the basically anteroinferior tibiofibular ligament injury, chronic injury leads to the impingement of ankle joint anteriorly, anterolateral part. The Ferkel first stated that this anterolateral synovial tissue and many a time redundant the ligamentous tissue also cause joint irritation, pain, swelling, and of course there may be injury to the syndesmotic, that is the anteroinferior tibiofibular ligament. There may be chondromalacia to the talus and the fibula, or there may be inflammatory synovitis in case of anterolateral impingement of the ankle joint. MRI is very useful in diagnosing such type of injury, but in case of anterolateral impingement, if it is the diagnosis, and almost in 40% of the cases, the synovium is thickened in this anterolateral gutter. And most of the time, if conservative treatment fails, usually 4 to 6 weeks, so you can put the orthoscope in the ankle joint and you can confirm the diagnosis of clinical and the MRI. At the same time, you can do debridement if synovium is inflamed and the thickened, or capsule is inflamed or thickened. And also, you can do the debridement of the anteroinferior tibiofibular ligament. But the care should be taken here that it should not be completely safe if it is ligamentous impingement is there. The at least remnant of the ligament should be preserved as much as possible. The posterior impingement, it is also known as the dancer's heel, because dancer used to keep walking or dancing on the plantar flex ankle joint. And in maximum plantar flexion of the ankle joint, there is impingement in the posterior part is there. And it may be because the bony impingement or soft tissue impingement. In soft tissue, there is irritation of the flexure hallucis longus or thickening of the posterior capsule. There may be synovitis. There may be inversion, repeated inversion trauma or a sprain is there. So most of the time, this is the force plantar flexion that leads to the impingement in the posterior side, and maybe there may be hypertrophy of the os trigonum is there. And this is also known as the posterior tibiotalar compression syndrome, or it may be os trigonum. Trigonum is the most common cause of symptomatic posterior ankle impingement. Like this is the anatomy in the posterior part, where the posterior inferior tibiofibular ligament is there, posterior ligament. This is the os trigonum. Here you can see it. Here is the os trigonum is there, and the posterior tibiofibular ligament is thickened. Hyperintensity, increased hyperintensity is there. So this is the impingement, and you can identify with MRI also. And when there is any confusion, you can diagnose with the posterior ankle arthroscopy also. So again, treatment in such type of cases, most of the time conservative only. Once conservative treatment fail after 6 months or even after injection of the steroid and all these things, conservative part, then operative should be applied. And as usual, is most of the time it's debridement of the impingement, whether it's soft tissue or bony spur or os trigonum. So literature says, particularly in dancer or athlete, if it is the posterior impingement because of the mechanical part, excision of this mechanical part gives a very excellent result in such type of the cases. The next soft tissue problem in ankle is the syndesmotic injury. This is the anatomy of the syndesmotic, that is the anterior inferior tibiofibular ligament, the posterior inferior tibiofibular ligament, then there is transverse ligament is there, then an interosseous ligament is there. So function of this ligament is to maintain the congruency of the tibiotalar. interface under physiological axial load when patients start walking, running, jumping. And the literature says the complete disruption of the syndesmotic and the deltoid leads to the 40% decrease in the tibiotalar contact area. So the contact area get reduced, and that leads to the increase in the contact pressure between the tibia and the talar, almost 36%. So, so if it is isolated syndesmotic injury, many a time it's become difficult to diagnose, particularly when there is no opening in the distal tibiofibular joint, even under stress. Or if it is incomplete syndesmotic injury is there, then again diagnosis become difficult. Though MRI are sensitive, almost 96%, particularly in the complete tear, but for incomplete tear, MRI is also not very good diagnostic tool. So if you put the scope in the joint, you can see this is the syndesmotic ligament, this is the tibia, this is the fibula. So it's connecting, this is the anterior inferior tibiofibular ligament. But once it is torn, so you can see, you are seeing from the anteromedial portal toward the anterolateral side of the joint. So this is the torn, this antero-inferior tibiofibular. Similarly, in the posterior part, it's the same. If you insert your scope in the posterior part of the ankle joint from the anteromedial side, so you can see the posterior inferior tibiofibular ligament that is intact. This is the tibia and the fibula. Here it is torn. So making diagnosis of syndesmotic injury with arthroscopy is almost gold standard. Many a time ligament remain attached, but still there is problem with the syndesmotic ligament. So there are some criteria is there, particularly the arthroscopic criteria is here for diagnosis, for making a diagnosis of torn ligament. That is abnormal course of the syndesmotic ligament, or there is decrease in its tension, or of course avulsion from either of the side. We can see very beautifully with the arthroscope. At the same time, the positive arthroscope stress test that the opening of the tibiofibular joint. So like this, you can see here, in case of increased opening of the tibiofibular joint is diagnostic of this torn syndesmotic ligament. Next is the lateral ankle instability, particularly in the chronic ankle instability is there. So many a time with the chronic ankle instability, there is a lot of intra-articular pathology associated with this. This may be because of the primary trauma, or this may be because of the repetitive instability of the joint because of the deficit of the ligament is there. So Giovanni says the opening inspection and the management of the intra-articular lesion at the time of ligament reconstruction, this improved the surgical outcome. And also at the time of modified Brostrom procedure, if you combine the ankle arthroscopy with the reconstruction of the ligament, this gives the better outcome. But literature in 2019, this was the systemic review and the meta-analysis, says the outcome of the arthroscopic lateral ankle ligament reconstruction to be the gold standard, being well documented with the open procedure. So, but there is no significant difference in outcome in early, if you see the early duration part. So even though it's the gold standard, but there is not very difference with the open part. Again, another literature in 2017 is American Journal of Sports Medicine, whether you do the ligament reconstruction by open method or arthroscopic method, there is hardly any superiority of the arthroscopic method. Then the bony pathology in the ankle, the first is the anterior bony impingement is there. Again, this is called as the footballer ankle or athlete ankle, because in such type of athlete needs the force dorsiflexion of the ankle joint many a time. That leads to the pressure over the talus from the anterior margin of the tibia. So this was a case of anterior bony impingement. In this case, the spur was both with the distal part of the tibia and the talus also. So the arthroscopic excision of the spur from both the tibia and the talus was done. This almost, I think, a year back. But many a time in chronic cases of this anterior bony impingement, the improvement is not so much significant. Like in this case, those who are having athlete, young population having 6 months, 1 year of duration, the result is excellent. This patient was not very much satisfied even with this much of excision of the osteophytes from the distal part of the tibia and the talus. Next bony lesion is the osteochondral lesion. Most commonly, osteochondral lesion of the talus in the medial part of the talus. And this was the case of osteochondral lesion of the talus. Here you can see, and orthoscopically, this you can see here there is a defect, and also the surrounding the cartilage is also very loose. So in such type of cases, you have to make a stable cartilage around the defect, and then you do the microfracture. So the microfracture you can do with the awl, and or you can do with the simple microfracture drill is there. So nowadays the concept of doing the microfracture with the thinner as much as possible, usually 1 mm or 1.5 mm. Because with a problem with such type of awl is the diameter is bigger, so and the chances of damage of the subchondral bone is high. So the one of the biggest cause of failure of microfracture was the subchondral bone was not very supportive once the cartilage was restored in the defect side. So the drill side has this microfracture drill diameter has decreased almost up to 1 millimeter or 1.5. And this was the long-term result of the microfracture. Almost at the end of 6.7 year, or 15% having needs repeat surgery. So again, up to 12 year, 50%, 12% repeat surgery. Almost at the 10 year, another literature says the 57% were symptomatic. Also in the microfracture, the osteochondral lesion of the talus, size is also very important. The literature says the size between the 10 millimeter to the 15 millimeter having excellent result with microfracture in comparison to the size were treated with the bigger size were treated with the microfracture. So size is also very important. So nowadays there is a lot of discussion about the adding the PRP and the VMAC with this microfracture part once the microfracture part completed. So the need for add the VMAC or the PRP. There's a lot of animal study that is the promising, but even this good evidence need to be support all these adding to microfracture. Like this Aman 18-year male, again having similar lesion, but here along with the microfracture, there is a lot of very big edema in the talus was also. Subchondral bone was also not very good. 18-year male only, so he was treated with again with the microfracture, arthroscopic microfracture. But at the same time, the biological augmentation was done by taking the bone marrow splits from the tibia and it was injected in the talus. It was not like VMAC, but just bone marrow split was. But again, he back after 15 months only with the symptomatic pain around the ankle. So you can see this lesion size has decreased. And this was the sagittal section is there. This was the previous one, and this was the recent one, but patient is still symptomatic. You can see almost the displaced cartilage over there. This part has not healed, and the patient is too much absent. This was the MRI in March 2018, and this was the MRI in May 2019. So option left after failed a symptomatic microfracture, patient is that you can do again microfracture, re-microfracture, or you can do the OATS or ACI or other things what we have available. So in this case, we plan for the OATS procedure. So first K-wire was passed, and this was the tunnel was made with the K-wire. Then the osteotomy of the medial malleolus was done, and the lamina distractor was used to see the defect. So this was the defect after making a stable cartilaginous margin around the defect. And this defect was made almost 15 millimeter of depth with the help of this OATS system is there. So, and after that, the plug was taken from the knee and the suprapatellar area of the femur. This was how it should be placed perpendicular over the femoral condyle and almost in the peripheral part, that is the non-articular. So one plug was placed here and 10 millimeter again defect was there. This was the defect left. So another plug was placed there. So two plug was placed, then the medial malleolus was fixed with the two fully threaded screws. And this was the lateral view. And now patient is asymptomatic. So almost now it's 3 years. Now 4 years has passed. That X-ray is not here. We can find this X-ray of May 2022. So that patient was operated in 19 May, and this is 3 year follow-up. Now 4 year follow-up we have. He is playing football. We can say occasionally he has little bit of intermittent swelling after playing of 1.5 or more than 1 hour of football. He is a football player. He loves to play football. So occasional swelling last time he complaining of. So this is the recent X-ray. The Amsterdam foot ankle groups, very famous group for all these ankle and the foot arthroscopy, have developed the new technique for treating this osteochondral lesion of the talus. That is called as LDFF. That is you lift, drill, fill, and fix. So in this, what you do, just lift the damaged cartilage and you do the drilling, then the fill the defect, and then you fix with this lot of suture or anchor that damaged cartilage. And all these techniques can be performed all arthroscopically. They have published this in 2018 also. And next, the new thing about the ankle arthroscopy is the orthoscopic assisted fracture care. That is, a lot of surgeons start putting a scope at the time of fixation of the ankle fracture. Because the high incidence of the condyle lesion and other intra-articular abnormality during the ankle fracture. So that almost it was up to 80%. That was in a study of 288% that was published in JBGS 2000. So it's orthoscopy give the clear visualization. At the same time, the other ligamentous injury can be assessed very easily with the help of orthoscope. So, and at the same time, there is potential for their concomitant treatment during the fixation of the ankle fracture and the talus fracture. And again, this ankle orthoscopy is very helpful in triplane injury in the children. And Chen recently published in 2019 says the orthoscopically during OREF of the ankle fracture, almost 92% of the ankle were having some kind of loose body, particularly in the supination type of fracture. If that ankle orthoscopy was not done, that would have been missed. However, there is retrospective descriptive series like these provide the valuable information on amount and the type of concomitant injury in the ankle fracture. It's remained unclear whether these adding the arthroscopy to these type of patient, this will be beneficial or not. And at the same time, its evidence has to be proved about the use of arthroscopy in trauma patient. The next recent thing is the needle arthroscopy. So this needle arthroscopy already has started in the knee joint and shoulder joint almost 6-7 years back. So this is the arthroscope is there. It's the single time use. It's that is called as the nanoscope. It's almost 1.9 millimeter, and they say it can be done in OPD also. So you can do the diagnostic arthroscopy of the knee joint, shoulder joint, and ankle joint at the same time in OPD. It's a OPD procedure, just like you are putting a needle in the joints. Similarly, you can put a scope under local regional anesthesia only, and you can visualize the complete joint with this scope. Amin who justify the use of this needle arthroscopy. Gill also says the needle arthroscopy shows the more detailed information than the MRI. And other author also confirmed this. So in the masses, in the orthopedic field, more and more arthroscopic procedure which have been basic treatment option or no question whether they are really more efficient than the non-operative treatment or not, because like doing arthroscopic treatment for the degenerative knee or subacromial decompression, now it's taken as the non-superior than the conservative treatment. So the main practical recommendation that we have to prove now successful our arthroscopic surgery by documenting all the procedure, preferably by joining force and conducting the large multi-center randomized clinical trial. And also we have to keep in mind that with this right tool, we can do almost anything, but we should always be aware if this procedure we perform really benefited the patient. Thank you.
Okay, thank you, Arvind. That was excellent. And I'm sure there are a lot of questions. So we will progress to that. There was one in the chat box about when would you use the anterolateral portal? And do you not use it at all, or are there particular indications for using the anterolateral portal?
So most of the time in ankle arthroscopy, the anteromedial is the wing portal and the anterolateral is the working portal. But once you have to see on the medial side of the ankle joint, like medial malleolus or any loose body on the medial gutter, so you switch the scope toward the anterolateral side. So now anterolateral side is the wing portal and the working portal is the anteromedial part.
Yeah, but you said that the anterolateral portal is not used because of peroneal nerve problems. So if you use it as a surgical portal or viewing portal, that problem will still be there.
Central portal is not used.
Central portal, okay. So you can use the anterolateral, but you want to avoid using the anterocentral portal.
Yeah, interesting.
Okay. I hope that's clear to whoever was asking that question.
And it's changeable from the anteromedial to the anterolateral.
Yeah, anteromedial and anterolateral is not a problem.
If it is
And
synovitis,
posterolateral also is not a big issue, I guess, when you use it.
Yes, sir. So we got the response that he has understood that.
Sure.
So as you told about that, we can use this arthroscope for a syndesmotic injury also. So usually arthroscope is for when we are going inside the capsule. So for syndesmosis, how we can use that?
Inside the capsule, I think the syndesmosis is in the joint, isn't it?
yeah. So
Partly
we
in
are
the
not
joint.
damaging the
Capsule.
syndesmotic ligament. So basically, it's the just after the skin, the capsule is in front of you if you are on the right track. And as I remember, a very long time ago, almost 7-8 years back, there was a young lady with the pain around the lateral side of the ankle. The MRI was not very conclusive of that. Only clinical diagnosis was of syndesmotic injury. And we put the scope in the ankle joint and there was complete separation of the syndesmotic ligament. So that time we fixed with this adjustable loop. So you can very well diagnose this syndesmotic injury with arthroscope.
So one thing you told in your lecture that indication is one is the fusion of the joint. So
yeah. So many a time there is ankle arthritis is there. So in such type of cases, you just do the bud of the cartilage, and then you do the fixation part, whatever you are happy with. So maybe with the screws, it's for the removal of the cartilage with the help of bud. So minimal resection of the bone with under arthroscopic image.
So there is one question, sir, that ankle distractor to be applied only before arthroscopy procedure or during the whole procedure?
No, if you're using it, you would use it for the whole procedure. No? Why would you stop using it in between?
So basic principle is to create the space, because putting either 2.7 or 4 mm scope in the ankle joint sometimes become difficult. So principle, you have to create the space so that you can visualize the ankle joint in a good manner. So it's always better to have this distractor on all the time.
So what about a simple external fixator as a distractor?
I was just thinking that may be one of the things. Yeah, we have think about the using that, the simple distractor like femoral distractor and other.
Yeah.
That can be used. There is no problem.
And the other thing was whether when you're doing these drilling techniques or microfracture techniques, the idea of combining that with post-operative distraction of the joint.
Yeah, this again, that's why in the post-op, this is one of the idea that distractor. Another thing, we keep patient on non-weight bearing so that the stress over the microfracture area will be less. So this may be one of the good idea to keep distractor at the same time after doing the surgery for 3 weeks or 4 weeks or something.
Because we can use distractor for healing of the osteochondral lesion because there will be no pressure on it. And at the same time, the joint will be distracted. So it might help with mobilization. So you can hinge it after some time so that they can start movement as well, if you want. So with a laser off, you can hinge it so that you can move the ankle at the same time.
Do we need some special type of arthroscopes, sir, other than that OPDs?
You need a thinner arthroscope for the ankle than for the knee.
So,
Ideally.
yes, okay, sir. And sir, when I have checked the question paper for DNB, ankle arthroscopy has not yet been asked, although it is a very potential question because in recent advances.
If it hasn't been asked, it could be asked in the future.
Yes, but they have asked
about the OCD, that osteochondral lesion of the
especially for osteochondral dissecants and osteochondral lesions. I think it's a useful procedure, and especially with MRI today, we see a lot of these. I mean, it's not an uncommon diagnosis where they have ankle pain. And even on the X-ray, sometimes it'll show it, but the MRI really makes it very clear.
And they have asked more question, quite a lot question about hip arthroscopy.
Yeah, so hip is, hip arthroscopy is also trending, but I think ankle arthroscopy is also gaining ground, as is ankle joint replacement. Okay. So gradually the ankle joint replacement is becoming a more popular procedure than was earlier. Okay. But the problem is availability of the implants, etc. in India at the moment.
So one more question is is there any contraindication for the procedure, or do we need to use pump as we use in knee arthroscopy?
So in knee, usually we don't require pump, but definitely, in ankle, if it is available, you can use. There is no problem because you need distension of the joint.
And about the contraindication, sir?
Contraindication of pump?
No, sir. For the procedure, this procedure, ankle arthroscopy.
So about the contraindication, so it's depend upon in which indication you want to use basically. So if there is chances of just like if you are not very sure about the vessel and nerve, particularly there is saphenous vein on the medial side is there, then the superficial peroneal nerve is there. If you are not very sure about that, so it should not be applied.
So in your lecture, sir, you have used one term LDFF, that lift, drill, fill and fix. That is for OCD, sir.
One more thing, Janki, about the stiff ankle. It's if it is very stiff, there is a space, is hardly any space in the ankle joint. Then again, if you put the scope in the joint, the chances of injury, further injury will be very high.
Yeah, and I think once the joint space is already sort of grossly reduced and you have advanced osteoarthritis, then it becomes difficult to scope the joint. Okay.
Yes, sir. So just the last question, sir, that LDFF is for OCD, sir. What you have to lift, drill, fill and fix here. That is for
lift, drill, fill and fix. That is for the OCD, osteochondral lesion. The cartilage is almost separating from the bone. The subchondral bone is not very good. So you orthoscopically separate the cartilage from the subchondral bone, do the lot of drilling part inside this, then you fill, then fix with, nowadays there is a lot of biodegradable implant is there. So you fix the remaining cartilage over that. And this Amsterdam group says the result is very convincing with this technique. They are doing almost for 5 years now.
Yes.
There is a lot of literature also over there.
So, and sir, that just microfracture, how to decide between these two, sir? That you need to fill it, or just microfracture is enough? How to decide between these two about the OCD, sir?
So basically, we usually either doing microfracture or OATS, that is the osteochondral transfer of the plug. So if size is around 1 to 1.5 or maximum 2 centimeter, so we can go with the microfracture. But if his size is bigger than 2 centimeter, then there's this osteochondral OATS procedure will be perfect for that. At the same time, even if size is lesser, but it's not only the pathology with the cartilage or subchondral bone. If the pathology is deeper, then in such type of cases, again, the osteochondral OATS procedure should be performed.
Yes.
So where do you take your OATS graft from?
So preferred side is the knee, the suprapatellar
Okay, so you have to go to the knee again.
Yeah, knee.
Like when you do it for the knee, you take it from the knee itself, because you have areas of the knee which are not weight bearing.
So in our country, we have this autograft only, but in Europe or USA, in 99% of the cases, they are using yellow graft type of thing, the freeze dried, and they are just taking the same size. So they have advantage of making bigger osteochondral plug also. Like in our case, it was almost defect of was 2.5 centimeter, 3 centimeters. So 1.5, 2 plug was there. So if it is allograft, then directly 3 centimeter plug can be placed there by exact cutting instrument.
Yeah, so there are places where they're also using osteochondral grafts which are specially stored.
Yeah.
Okay, so in a particular solution which allows the chondrocytes to remain viable when they graft it. So there are a few centers in the world which are doing this. Around the knee, they're doing transplantation of the entire condyle. Okay, so those are some of the advances that are actually making a huge difference to management in the younger patient.
So one question DNV has asked about the role of arthroscopy in intra-articular fracture. So
Yes.
So you
Just to
discussed
brief
that,
it for,
isn't it?
yeah,
That
yes,
was
sir.
discussed. So,
If it is for the long question, then what
so
else?
then you talk about various fractures. Now you can use it in the knee, you can use it in the ankle, you can use it in certain things in the shoulder, like a Bankart's lesion. You can use it for elbow, not so much yet, but I think it could be there in the future for
So even
intra-articular chondral fractures. I'm sure there'll be an sort of indication for that.
so even
Just
for if
Just
it
like one patient
But in
is,
knee, it's being used quite extensively in some centers. So by and large, the principle is that you don't use it when there's a lot of soft tissue injury. So for type 4, type 5, type 6 injuries, you would avoid it. But there are centers which are doing it even in those.
so
Except that they don't use pressure with the solution.
so even for the open reduction, sir, if we are not opening the joint, then arthroscope will help the assisted procedure.
Exactly. So that's what especially for the pure depression fractures. Okay, so you elevate it and then view it arthroscopically.
So die punch type. Okay, sir. Yes.
similarly, one case is in our ward, that is the proximal tibia fracture. I mean, this ACL spine avulsion was also there. That was not very confirmatory with this. So after fixing tibia by putting the orthoscope inside the knee joint, so ACL spine avulsion was also there. So we fix with this.
Okay, I think that's
one
great.
last, yeah, just one question they have asked right now, sir. If there is an associated posterior lesion to the ankle in addition to anterior lesion, position of patient in that case.
So if it's only the posterior part is there, then it's always better to have in the prone position. But if you are suspecting that, you may have to do the posterior ankle arthroscopy, like posterior os trigonum is there or posterior spur is there. So you can do in the lateral position and you can get rid of this.
Do it in the lateral with that ankle on top. Okay, so
You have to be free behind this table.
Thank you very much, sir.
Okay, thank you. And until next week, bye everybody.
Yeah.
And thank you very much, Arvind, for an excellent presentation.
Good night.
Yeah,
Thank you very much, sir. It was
Okay,
great.
bye.
Thank you, sir.
Hey. Five. Come. Oh, my stomach. Hey. Color was white. This color was blue. The chocolate. This is birthday so green. This is number so divine. Number 7. Number 7. Number 7. That's a color like blue. This is color like white.